Sorry, thank you. And please remind me if that happens again. So we're going to touch on gender differences across the lifespan. So looking at females versus males with ASD. Is that better? Can everyone hear me? Perfect. Big change. And this idea of camouflaging. So some of the big questions that you'll hear tossed around when we're thinking about this kind of hot topic right now, that females with ASD, is whether autism might present differently in girls and women with ASD, and whether symptoms may be more subtle or they may be masked or camouflaged in any sort of way. And then does that mean that therefore females may be less likely to be diagnosed or diagnosed later? And then again, like I mentioned, what do we do with this information if we know there are some differences? How do we support these girls and women? So some of the things that we do know from research does show that there are some of these differences diagnostically. So we know that females, girls who are diagnosed after the age of 5 are more likely to be diagnosed about a year later on average than boys. Under 5, it seems like diagnosis is happening similarly, but what is happening in this group that's diagnosed after 5 that maybe these girls aren't being recognized as readily as boys? And the other thing that we know is that girls who don't have accompanying intellectual disability or challenging behaviors are also less likely to be recognized, even when they have the same levels of kind of those core impairments that we think about in autism, or core difficulties, social differences. They still may not be as likely to be diagnosed as boys. So when we look at prior research, even up to a few years ago, there was a general thought that girls did look a little bit different than boys, but that profile looks a little bit different than what we think of now. So before, when we looked at data about girls who had been diagnosed versus boys who were diagnosed, we saw that the girls, compared to the boys, tended to have lower cognitive ability, which sort of mediated this greater difficulty with social communication difficulties, differences in those restricted interests, intense interests, repetitive behaviors, weaker adaptive skills, and greater externalizing problems such as irritable behavior, not having a lot of energy, lethargy. So this profile of the girls actually having more difficulties than the boys who were diagnosed. But in recent years, when we look at the research, we see that that really wasn't capturing what we know about girls and women with ASD, and that there is this sort of second profile of girls who are maybe previously missed, who do have higher cognitive abilities and fluent speech, and potentially above average cognitive abilities and fluent speech, and that these girls and women may actually have less social communication difficulties, or they may look different than the way males' social communication difficulties look. But one of the questions is, and we'll dive into this in a little bit, but is that social communication difference, is that present throughout the lifespan, or is that maybe a difference that occurs at certain points in development? So we'll talk about that a little bit. And I'm losing my name tag. Hazard of long hair. All right. So, and then we have some research to show that in this profile in women with ASD, girls with ASD, that there may be differences in the way that restricted and repetitive behaviors criteria is manifested. A different type maybe, as opposed to a different level of severity. So we have a broader picture now, right? This means that females are really spanning the spectrum more than we previously thought. But there might be these kind of two profiles of what we see in girls and women with ASD. So in trying to provide the initial diagnosis to girls and women with ASD, we have kind of posited and discussed in the literature multiple things that are impacting the ability to make the diagnosis and that make it a little bit challenging sometimes. And one of the things that has been discussed a lot, but not a ton of action has occurred yet, is this idea that when we developed the measures that we use to make diagnoses of autism, they were really developed based on research samples of mostly males, right? Because at the time they were developed, most of the individuals who were diagnosed were males. So that could be problematic in the sense that these tools aren't sensitive to differences that we may see in females. Another issue is just that girls are socialized differently than boys by nature. All girls, right? All girls and all boys. So knowing that girls may be socialized to be more social, the expectations are higher. So one thing we know is that mothers tend to talk to their daughters with more emotional references. They tend to talk about feelings more. So this may lead to girls then being more sensitive to these types of emotions in others and to be better able to talk about them. And so that may lead to a more subtle presentation in girls with ASD who have had a lot more exposure to that than boys per se. So that may be contributing to the picture. And then we know from some research that girls with ASD tend to be less recognized at school. And this has to do with a couple of things. One piece of it is that we know that when we have families fill out these diagnostic rating scales that we often have families fill out as part of the diagnostic process, that when we look at the results from parent scales for boys and teacher scales for boys, boys with ASD tend to come up pretty elevated on these scales for both the parent report and the teacher report. So the parent and the teacher are seeing symptoms of ASD. But the girls, the parent report often comes up more elevated, and the teacher report may come up kind of borderline elevated and more elevated than, say, the sample of typically developing girls, but not to the level that the boys' report seems to come up. So again, just a more subtle presentation and may speak to this idea of, are the girls able to compensate in some way in school, or are they masking symptoms in any way? And then this idea that girls with ASD tend to have less behavior that calls attention to them in the classroom, right? So ADHD types of behaviors, hyperactivity, those things, or challenging behaviors, aggression, things like that. So if girls are less likely to have these types of behaviors, they're not maybe getting the teacher's attention in a class of 30. So something to consider as well. And then this idea of camouflaging that we'll talk about more in a little bit, but just this idea that girls may be able to mask their symptoms in the classroom could be contributing to teachers not being as aware right off the bat. So thinking through the diagnostic criteria for ASD, one of the things that we look for is this idea of restricted and repetitive behavior. So patterns of play or interests that are more intense or more repetitive than we might expect. And the sensory differences, things like that. But research is showing us that these behaviors may be less predictive in females than males of diagnosis. So something to be aware of. And so we look at the research and we see that there's somewhat mixed findings in this area, and it's not a closed book, so there's still more work to be done. But there seems to be some research that shows that girls and boys with ASD show similar overall levels of restricted and repetitive behaviors, intense interests, and things like that. But then some research shows that they may have lower overall levels of that, and that there are similarities in sensory differences. So nothing notable there in the research. But what is notable about this category is that the way girls' restricted interests, so those intense interests that we would expect to be more, come up more often, more talked about, more focus of what girls or boys with ASD tend to play on that topic, talk on that topic, the interests seem to look different. So while young boys might be very interested in very hyper-focused on things like trains, or Legos, or those kinds of object-focused things that we think of often as restricted interests in ASD. Girls with ASD may have more socially directed interests or more typical interests. So it could be something like My Little Pony, which would be very typical for a girl. It's just the level of intensity of that interest is quite a bit higher. So that can be really challenging to distinguish, right? Just thinking about where's the line of, is this intense enough? Is this enough of a focus to warrant calling it a restricted interest when it's a pretty typical interest for, you know, a girl of 7 or 8 years. Sometimes we do see that these interests can persist to a point that may not be as, maybe a little bit socially immature, so that can be kind of a red flag as well, that it may be something that looks a little different. But it can be really hard to distinguish when it's these kind of socially directed behaviors. So that's something to be thinking about when we're considering diagnostic criteria for girls and women. So thinking about kind of the core social communication differences that we see in autism, there are a lot of studies that do show that there aren't differences in males and females across social communication. So, you know, that back and forth nature of being able to engage in conversation and for younger children play, that there really aren't that many differences in males and females. And that's particularly true for the kids who do get a diagnosis in preschool, so that under 5 group looks pretty similar. But then the question arises again, is this a function of the diagnostic tool we're using? Is this a function of the fact that it's been based on a male research population and the tool is not capturing it? And when we're doing the research, or are we comparing just those individuals who have received a diagnosis, right? So maybe those individuals who have received a diagnosis across girls and boys are more similar, but what if we're missing some women out there? So, just some questions. So thinking about, is this idea of camouflaging contributing potentially to that kind of trajectory? Are girls able to mask their symptoms or differences in some sort of way? And when we talk about this concept of camouflaging, there are 2 things that kind of come up. One is this idea of girls being able to mimic others, so maybe being more socially attentive to the environment and looking around and seeing what others are doing and just sort of following along and picking up on that as a way of fitting in and not sticking out. And then this other concept of compensatory strategies, referring to actual, like, more planned methods of being able to pick up on social skills. So, you know, really practicing using good eye contact, or you know, preparing in advance for a social situation, planning out the script in your head, things like that. So these strategies that help them to fit in or avoid others thinking something negative about them or feeling labeled. And so thinking about school age, when you think back to that graphic and the big gap, right, at school age where boys with ASD were having more difficulty, more symptomatology than girls, thinking about what are the differences at this age. So this is another really interesting study by Dean and colleagues done in 2017, and they did a structured observation of girls on the playground, girls and boys. So they observed girls and boys with ASD as well as typically developing girls and boys with ASD. And they found that, unsurprisingly, there were differences between girls and boys in general. So girls on the playground in elementary age children tend to be more jointly engaged than boys, period. They tend to do more talking than playing structured games, which is probably not a surprise. And girls, even when they are playing structured games, tend to continue that talking all throughout. So even when they're moving around, they're jointly engaged with their peers, and that's really the focus of their social interaction or their playground play. Boys with ASD were pretty clearly found to spend the most time playing alone. So again, thinking back to why teachers might not notice girls as much as boys, the boys are often playing alone on the playground potentially. Girls, on the other hand, tended to stay close to their peers, girls with ASD. So they tended to stay close to their peers and sort of weave in and out of whatever activity is happening, which is actually what a lot of girls did. All the girls tended to move from one activity to another, like I mentioned, talking all the way. The girls with ASD aren't necessarily doing this engaged talking while they're moving from one activity to another, but they are moving around. So you can imagine, and they're staying with the group. So you can imagine as an observer, it might be pretty challenging to pick that out. So this idea of them being a little bit camouflaged on the playground kind of fits with this scenario. Another pretty recent study that's definitely a preliminary finding, but is interesting, was an eye tracking study where they had children ages 6 to 10 look at these different images and saw which of the images they were paying more attention to. So looking at them, one of them is more social than the other, right? And sometimes it was a random object as opposed to a face, but sometimes the other object was something that might be a common restricted interest or a common intense interest in ASD. And what they found is that girls with ASD, girls overall, typically developing, and girls with ASD tended to look more at the faces than boys, period, which again fits with this. Girls have more social motivation potentially or have been socialized this way than boys. The difference between typically developing girls and girls with ASD was not really there, as opposed to boys with ASD who tended to look more at the objects than we might expect as compared to the typically developing boys. And again, this is kind of a preliminary finding, but fits with this overall picture of girls potentially presenting as more subtle and being a bit more socially motivated and being able to maybe mask some difficulties based on that. So this is just kind of a recap of some differences that we see in, or that studies have found in that kind of school age range of girls with ASD. So this idea of social motivation differences, a tendency for the girls to maybe be more passive and shy. So again, that fits with this idea of not necessarily sticking out or being noticeable. Potentially camouflaging, having a few friends or one friend at this time, and peers maybe being kind or inclusive during this time, but then later in middle school, these girls experiencing more bullying. And in the communication realm, just thinking about how there might be some play differences. So these girls might do some pretend play and maybe are a little bit better at this than some of the boys with ASD, but they can be a little bit rigid and controlling in their play and directive. So that's a difference from typically developing peers that we might see with girls. And then again, this idea of the restricted interests being a little bit more socially directed as opposed to boys. So all things to be thinking about. So that brings us to adolescent girls. So we get to the end of that curve and we're thinking about, have girls with ASD sort of caught up in terms of social difficulties potentially. And a lot of the studies about adolescent girls are qualitative studies where researchers interviewed adolescent girls about their perspectives on being an individual with autism and how they're coping, which I find really interesting. to get that perspective. And so just as some background, we know that typical adolescent girl friendships tend to revolve around small groups of friends, more of an exclusivity, this need for a lot of intimacy in your relationships, feeling like you can disclose and keep secrets, and again, that pattern of talking in lieu of playing structured activities for girls as opposed to boys in general continues. We found, research has found that looking at female friendships for girls with ASD as opposed to typically developing girls, that there are a number of similarities. So girls with ASD tend to define friendship the same way in adolescence. They tend to place as much importance on it as typically developing girls, feeling the desire for friendship and being motivated to have friends. And I think that's important to remember. And the activities that they want to engage in with their friends or do engage in with their friends are similar. So going shopping or wanting to watch movies or have sleepovers, those things are all the same. And we know that adolescence for girls and boys to an extent is a time of conflict, and for girls it's often that relational aggression, and that holds true for girls with ASD as well. So some differences that adolescent girls with ASD report are just having fewer friendships, but maybe more intense friendships, and feeling that it's important that those people that are their friends allow them to let me be myself. So finding friends who maybe also have ASD, some of the girls cite, or also have some social difficulties that they can relate to is sometimes a pattern. And then this report that these girls with ASD often want to have more of a one-on-one interaction, struggle more with group social situations. So one individual cited having trouble navigating too many opinions, and citing this idea that in those group social situations it can be difficult to understand what others' expectations are, what should I be doing, am I reading the cues. All of the multiple social interactions that are happening in those group settings are challenging. And these quotes I thought were meaningful, just about how that can be draining for some of these adolescent girls, causing them to just want some time to de-stress afterward. And again, so some other differences. So that relational conflict was across all girls, but girls with ASD tend to often be the victim as opposed to the aggressor in that situation. And then when girls with ASD did get into conflicts with friends, say, they reported having more difficulty than typically developing girls in knowing how to manage that conflict. So they were trying to manage and resolve that conflict, but the typically developing girls reported more like back and forth problem solving in terms of how do we solve this problem so it's a mutually agreeable solution, whereas girls with ASD were more likely to report either just taking all of the blame in order to solve the situation and preserve the friendship, or just deciding that it wasn't worth it and sort of ending the friendship. So having more difficulty negotiating those nuances. Another thing was this decreased sense of competition. So neurotypical girls reported being kind of competitive as adolescents with their friends, so wanting to be more popular or wanting to this and that, but that really wasn't a theme across girls with ASD. So it's something that could be kind of protective, actually. And then another thing that's interesting is that these girls did report being affected by social exclusion, but their parents reported being even more affected than the girls themselves, just by reports of, their child having difficulty fitting in or being socially rejected or things like that. So affecting both individuals, but really affecting parents.
what implications these have for supporting females with autism. So as Erica highlighted in her first part of the presentation, there's still a lot that we don't know yet about diagnoses, right? So I think these have a lot of important implications for clinicians who are considering whether a female does or does not have autism. And in reviewing the literature, there's been a couple recommendations made thus far. One of them has been using multiple tools, incorporating a mixed methods approach to identifying women. So a typical approach that other individuals may go through of going to see a pediatrician or a psychiatrist and being evaluated within a single discipline fashion may not be the best consideration for a female when you're considering if that person has autism. The literature has also suggested some value for combining multiple different tools. So the ADIR and the ADOS are currently two gold standard diagnostic assessments that we use in the field. Some have suggested the benefit of using both of these as part of an autism evaluation. The ADIR is purely a parent interview, whereas the ADOS is an observation-based, more structured, interactive assessment. So there may be value in combining perspectives from parents as well as direct observation when considering if someone has autism. On top of that, look for specific response styles. So we know that the current autism tools that we have been standardized more largely on males, because right now the estimate is that there is a 4-to-1 male-female ratio in the autism community. So a lot of these tools have mostly been developed on males, they're therefore more sensitive to males. So we need to probably pay more attention to behavioral features that are tracked as part of these assessments, rather than simply relying on whether that person meets a specific cutoff score. And then also, clinicians are cautioned to, or they should take to caution when considering females with higher verbal abilities. As Erica mentioned, there's other variables going on, such as camouflaging, and may have subtler symptoms that may make it more tricky to identify those core features. There have been some tools, excitingly, that have been developed recently. These are parent report tools, but they have been specifically individualized for females. One of them is the Autism Spectrum Screening Questionnaire. So this was originally developed as a parent report, and authors a few years ago added 11 items that is more specific to identifying the features of females in using this tool. So the limitation is that, of course, it's difficult for us to research females because they're difficult to identify and find. So while there has been some good preliminary evidence supporting the efficacy of this parent screen, we need to further evaluate this in a larger community sample before it could be used more widely. And on top of that, it's a parent report, and we know that we can't solely rely on parent report to make diagnoses. Another tool that's been adapted is the questionnaire for autism spectrum conditions. This is actually a tool that was developed by Tony Atwood, who is a researcher over in the UK. He's been doing a lot of work in gender differences for quite some time. And he, I think, did a really nice job trying to incorporate more items in this tool that are more sensitive to the gender differences between males and females. Again, we need to evaluate this screen further in larger community, the larger sample sizes, before we can recommend using it as part of a diagnostic evaluation. So for the second half of this presentation, I'm going to be focusing on supports and what we can do to adequately support girls and females with autism. Now, the good thing is that this has been a growing topic of research interest in recent years. In fact, one of the leading research journals on autism, aptly titled Autism, recently published a special issue focused on females. But there isn't a whole lot of research out there on what we can do to adequately support women and females. So I've taken recommendations that I'll share with you from multiple sources, some from the research literature, a lot of the literature that's been published that I'll be talking about is based on parent reports and parent focus groups. And that's actually what I used to build this slide here, because these are areas that women with autism as well as parents have identified as concerns. And looking at this screen, if you can read it in the back, and thinking about people that you know, or if you yourself have autism, are these areas that you have thought about in needing more support. So social skills, healthcare access, and life skills. Do these ring home with you so far? Seeing a couple nods. Okay, so these are informed by the literature, they're informed by what parent focus groups have said are important, and then also bringing in some empirically based practices from professional experiences that I've had in working with females with autism. So as I go through these, I invite you to think about if the females that you supported, or if you work professionally with females, and think about, have you used these strategies? Have they worked? Or are there other strategies that you have found helpful? And please, if you have, share those during our discussion. So number one, as Erica highlighted, there is a major need for social supports for females with autism. And we know from the literature that there are a couple recommendations we can make. Because girls and females tend to be more likely to be part of a social group but have difficulty sticking within that group, they flit in and out. The recommendations are that females should receive social skills supports within the context of group settings. And ideally, they should have access to peer mentors or models who can help model appropriate versus inappropriate social skills. Parts of these social skills training should also talk about different types of relationships, so romantic relationships. All of the social rules surrounding dating, that's a grey area in itself for all of us, I think, and I think particularly for females with autism. I think it's important that these programs address being a victim of bullying, because we know that's a big topic and area for individuals with autism. So social skills training is an empirically supported practice as an intervention for individuals with autism. And there are two programs that have been evaluated specifically for females, which is exciting. The first that I was really jazzed about was Girls' Night Out. And the reason I think it's so exciting is because it's just how it sounds. It's a girls' night out. So this is developed at the University of Kansas. What happened was they set up social scenarios where females with autism went out with peers who did not have autism, and they went to various community events, amusement parks, dance classes, slumber parties, and provided structured opportunities within the context of these interactions to work on not just practicing relating to others, but they also built in opportunities to practice self-care skills, which is an important area of emphasis for females with autism. And they also focused on self-determination. So this is another important area, and we're going to talk about that in a few minutes. Just to really focus on building self-esteem for young women on the spectrum. This model also used a variety of empirically supported practices, so peer mentoring, I mentioned that, modeling, role-playing, feedback, goal setting, and generalization of skills. And so a recent study that was published that was evaluating this model over the past 4 years with different cohorts found really nice significant improvements reported by female participants in self-perception, social relationships and friendships. Some of them reported being able to go out afterwards and initiate their own friendships with people, and quality of life. So that's a pretty exciting intervention that I think needs further attention. Also peers. Has anyone heard of the peers model before? This has been around for a little while. This was developed at UCLA. And while it hasn't been developed specifically for females versus males, a recent study that was published with a sample of about 177, so this is nice because it's a little bit larger, found that there were no gender differences between males and females in positive outcomes reported. So what this suggests is that this program, which is again a group-based intervention, may also be a good option to consider, or principles, a model to borrow principles from when delivering social interventions for females. And Erica's actually going to talk at the end about a social skills group that she's going to get started if any of you are interested in learning more about social skills. So mental health. Mental health is a really important area to focus on when we think about females with autism, because the literature has shown that there are higher rates of anxiety, depression, OCD, and epilepsy in women with autism than males. So thinking about those social difficulties that many females have, you can it's not too difficult to imagine that they may have a lot more social anxiety surrounding those social scenarios in adolescence, which may lead to depression And we need to make sure that we support women in these areas, particularly in considering adolescents. So mental health concerns are more likely to have an adolescent onset, and we know that females, as Erica mentioned, tend to be affected more severely by the social difficulties of social relationships when entering this life stage. We also have found, or there's been studies recently to show that teens and women have a higher use of mental health services than males with autism, and particular psychiatric services and visits to the emergency department as a result of being in a state of crisis. So this is an important area to focus on, is making sure that women are hooked up with appropriate mental health services, counseling, and those supports as they enter adolescence, should you suspect that there's a mental health need there. Okay, so who likes going to the doctor in the room? Show of hands. Nobody likes going to the doctor, right? So this is especially the case for females with autism. This is an extremely anxiety-provoking experience to go through for many folks, and especially when you're someone who has communication difficulties, or you may have sensory needs. Just thinking about a doctor's practice, it's loud, it smells bad, it's bright, it's noisy, it's stressful. This is a big issue for women with autism as well as intellectual and developmental disabilities more broadly. One of the reasons this is an issue is that medical providers, the majority of medical providers, have limited knowledge and education about autism and how to best support patients with autism. Unless you're a developmental or behavioral pediatrician or a psychiatrist with special emphasis in this area, physicians are not required as part of their medical training to learn about autism. So oftentimes when you, as a person with autism, are going into a doctor's appointment, they may not have any idea of how to effectively work with you as a patient, and that's a big deal, because oftentimes we know that women and girls need extra accommodations to have a successful healthcare visit. We also know that adolescent women and girls have reduced access to healthcare, and that oftentimes they don't get follow the recommended ages or the general guidelines regarding screenings, vaccinations, and screenings with regards to reproductive health that women without autism go through. So this is important because there's no reason to suspect that women with autism wouldn't be at risk of cervical or breast cancer and any other reproductive related health concerns than women without autism, but caregivers and physicians don't always recognize this need. A lot of the slides that you're going to be reviewing through have a couple different resources on them, and we'll also distribute a resource list at the end of our talk today. But here's one widget that I found that I thought was particularly useful. If you follow the link, all you need to do is enter your age and your gender, and it presents a list of the different screens that you should get at this age. So that may be helpful for women and girls with autism to know about, because it makes that information really accessible. A lot of women have self-reported anxiety related to going to a healthcare appointment, and even before that, waiting in a waiting room, when communicating with a provider, when describing pain and health needs. Describing pain is a very difficult thing to do for many of us, especially when you may have difficulties communicating more abstract concepts. So they would most likely will need additional supports in making sure that they can get their health and pain needs addressed. Once a female is distressed, it can become even more challenging to get these points across. So some strategies and some ideas that I've gathered from the literature as well as through personal experiences. Autism Speaks has an important and useful fact sheet about how to help support someone with autism through a healthcare appointment. So one of the strategies that I found helpful is calling ahead and discussing accommodations that a female with autism will need with a healthcare provider. Give them a heads up. Let them know if they find waiting for a long time particularly challenging, how they best communicate what their needs are, and try to set priorities for that appointment. Figure out, okay, if the female with autism gets stressed and finds that they're unable to successfully complete the entire appointment, what is the number one priority of that appointment that you want to get addressed if you need to end it early? Think about the time of the appointment. So who has waited far longer in a healthcare appointment than their appointment time to be seen? I think the majority of us, right? So thinking about trying to schedule that appointment at the beginning of the day or after lunch break, if that's applicable, so that you can get the female that you're supporting in as soon as possible without having to wait. One thing that I really liked and that I've done professionally is the use of an About Me fact sheet. So here's an example. If you do a Google search of fact sheets or About Me healthcare provider sheets online, this is something that you could bring with you to an appointment. So it's actually, I think this one is called a passport. It provides a one-page breakdown of what the individual's needs are, communication styles, what makes her comfortable, what makes her uncomfortable, to hand to the provider as you're going in or beforehand, so that person has as much information as they need to successfully get her through the appointment. And then beyond that, you can think about bringing other items like music, preferred people who know the individual the best, or items that help her keep herself distracted from the waiting environment. These can all be strategies to help ease anxiety of a healthcare appointment. Exercise. So exercise is a challenging area for many of us, as I think I told Hillary. Even for me, I have a membership to this beautiful gym and I haven't been for a month because it's cold and I don't want to come here. But exercise is a really important thing to stress for girls and women with autism, especially as they enter adolescence, because we know of the important health effects that exercise has, not just on physical health, but mental health and anxiety. So in thinking about promoting exercise, there are a couple different strategies you can think about incorporating, and again, I welcome you to share during our Q&A of what you have found helpful if you've been working on this for yourself, your family members, is consider fun options and involve your daughter or the female you're supporting in decision making. A lot of women, especially as they enter adolescence, want that independence because they are teenagers and adolescents, they're turning into young women, so they should be provided as many choices as possible about what they're going to be doing. So consider fun options that are going to be motivating, like horseback riding, Wii Fit, swimming, Special Olympics, because it provides that social contact. Reward healthy behaviors and choices, so if it's not inherently incentivizing to walk on a treadmill for 20 minutes, try to provide some rewards or some motivation after the gym visit so that the female you're supporting stays motivated. Create structure and schedule for routines and healthy habits, and this I think is easier said than done, but making this a family-wide habit, so making a structure in your day of when you're going to go to the gym or do something healthy so that it becomes an accepted part of the family routine can help also encourage exercise. And then modeling healthy behaviors by peers or family members. So several young women that I've worked with, families have been really surprised to find that they don't necessarily want to go exercise with their mum or dad, but they're really excited about the idea of exercising with a peer who they find cool or enjoy spending time with. So spending time with peers to socialize and exercise is also an important option to consider to make it more fun. One intervention that's been tested at the University of Ontario and Brandeis University in Canada is Women Be Healthy. And you can also Google this. This is a manualized intervention, and it provides really nice, concrete modules and examples of how to think about healthy eating patterns, how to think about exercise. It provides weekly homework goals, very straightforward information, and it's also the Parrish and colleagues study has found that women who have gone through this intervention had a significant increase in their knowledge about breast cancer checks and screens as a result of participating in this intervention. So not only does this focus on health and exercise, but also knowledge about reproductive health care. Healthy eating, another challenge for many of us in the winter months. So one strategy that has been recommended by families and individuals in the literature has been to maintain structure around those meal times. I think especially as girls enter adolescence, they may be more inclined to want to eat in their rooms or in front of the TV and just have some time to themselves. But it's important to think about maintaining that structure around the mealtime and having everyone eat at the table, because that not only provides an opportunity for healthier eating habits, but it also allows for more social interaction within that context. Again, reward or incentivize healthy choices, especially if fruits and vegetables aren't necessarily very appealing to the individual. And one strategy that I've used with some females that I've worked with is creating food menus and creating an array of choices. So essentially, for example, you map out 20 different options. About 5 of those are unhealthy or 10 of those are unhealthy, but you also have a good number of healthy options in there. And because choice and self-determination is so important, allowing the female that you're supporting or working with to select when she's going to have each of those options throughout the week. But once that option is gone for the week, it's gone and it's not going to be available again until next week. So that allows choice and self-determination, but also make sure that healthy options and unhealthy options are consumed. And there's another emphasis there about providing choices. This book, this picture of this book here was recently published by the American Association of Intellectual and Developmental Disabilities, recently won an award. Maybe some of you have seen this, but it has really nice strategies on working with your daughters or females on how to teach cooking skills, and within the context of teaching cooking skills, working on healthy choices while eating and preparing meals. So this is a good book. I know a couple people who've bought it have really enjoyed it, as it has some nice strategies in there to recommend when thinking about healthy eating. Okay, so now we're going to talk about hygiene, puberty and beyond. This is an important area when thinking about adolescent females with autism, because this is a big stressful change in many individuals' lives. And because it's stressful, because it's anxiety-provoking, and because it's a bit awkward, so who enjoys talking about periods in the room? Nobody again. I think a lot of us tend to avoid this topic, but it's really important for females with autism that we directly address the needs to engage in hygiene surrounding puberty. Of course, as we enter puberty, we see an increased needs to use deodorant, care for acne, other areas like that, body odor. So it's important as early as possible to directly address these needs to increase personal hygiene habits. Don't ignore these, don't put these off. You can provide extra supports to females in readjusting bathing and self-care routines and encouraging those increased hygiene habits in multiple ways. And again, this is going to be extremely individualized on what works best for the female that you know. But some examples are using structured visual or verbal supports to help readjust that morning routine, which we tend to have as a very structured and consistent routine for all of us, I think. So it takes a little bit of time and work to introduce those new hygiene habits. And also make sure you follow through and provide additional prompts to make sure that the individual engages in those extra hygiene tasks. Menstruation. So this is a whole new world, of course, for women as they enter this time of their life. And for many young girls with autism, it comes with a lot of anxiety and a lot of fear. I think there's importance to, as well, directly address this, reassure females that this is a normal part of life. Some females have reported in studies that I've read that they had an initial fear that they weren't ever going to stop bleeding when it started. And so that's very stressful, imagine feeling that way. So provide a lot of reassurance during this time that it's only temporary. There are a lot of visual supports that you can provide to help females get used to needing to check for hygiene during a period. For example, you can use calendars, period tracking apps to help your female learn how to predict when this is going to come on. Some females in some studies that I read reported that they really enjoyed using Apple Watches that vibrated at a fixed interval, for example, every 1 hour, so that they were reminded to go check and make sure that there were no leakages. And then also keep consistency and predictability surrounding the period that you can control. So keeping sanitary pads stocked in the same place in your house or the bathroom or her room, so that she knows where they're going to be. Provide a lot of role playing and supports. And a lot of mothers and parents of young women with autism who were interviewed within the context of some of these studies reported that it was really helpful for them to remember to be patient, because this is a big change for many women. It takes a while to learn these skills. So be patient and provide as much support as you can in learning, not just, don't expect essentially for someone to learn all of these 10 different steps in one go that you need to go through to successfully change a sanitary pad. The visuals you see there are some example, the top one is an example of all of the steps of changing a sanitary pad written out. And the idea is that you could post this in the bathroom and have your daughter or your friend check these off as she goes through these, or if this is a female who is unable to read, then you can use a picture format of this schedule so that she knows which steps to go through. There's also been some evidence in the literature that there's increased irritability and problem behavior during the week leading up to a period in women with autism. So if this is something that you're concerned about, consider tracking changes in mood and changes in problem behavior before and after a period to see if you can use this information to help you predict when a period is coming if that information is unavailable to you. And so sex education is of course another really important piece to talk about when supporting adolescents. Again, direct discussion is very important for women because there's so much ambiguity surrounding appropriate and inappropriate relationships. Try to use examples of couples and relationships that the female that you are caring for or supporting or you work with or whatever scenario it is. Discuss examples of why people get married or why people choose to live with each other, and using family and friends as examples so that they know what examples of appropriate social relationships look like. And it's important to distinguish between appropriate and inappropriate examples of safe sexual relationships and behaviors. I've worked with a couple young women who I don't think had this conversation with parents or family members, and so what I sometimes I was suspicious at times that they had learned examples of appropriate social relationships from soap operas, because they would go, oh my goodness, a very dramatic response to being slighted by someone that they were dating, even if he said something like, I can't see you this evening. And they broke up and she would storm off and she'd be so upset. So talk about these appropriate examples of relationships, who they should be paying attention to, who they shouldn't be paying attention to when learning these social norms. The Indiana Resource Center for Autism, we have the link on the resource sheet that we'll be distributing. They have a lot of really nice videos, interviews and resources that have been developed specifically for women and men going through puberty who have autism. So we'll share that with you. Sexual abuse is unfortunately an important topic to discuss as well. We know that women with intellectual and developmental disabilities are a much higher risk of experiencing sexual abuse than women without intellectual and developmental disabilities, and this also applies to women with autism. So don't delay the conversation about unsafe and safe behavior. I think another important strategy to think about, and this I think can be tricky, is teaching ways to say no and stop in response to unwanted touch. One mother that I worked with had she basically decided that she was going to poke her son, who was mostly nonverbal, just poke him until he finally said no, because she was trying to teach him that if you want someone to stop touching you, you need to say no. You need to say it loudly or say stop. It's not appropriate to just let it happen, right? So teaching those self-advocacy skills as early as possible is important. Also distinguishing what is an okay versus a not okay touch to you. We also need to teach accurate names of body parts, just so that there's no stigma surrounding sexuality, so that they understand, so that young women understand what the seriousness of these areas, and so that if something should happen, that they can talk about it appropriately and correctly. And be aware of warning signs. So the link on the screen is from Autism Speaks, and it has a lot of tips and tricks for recognizing signs of sexual abuse and preventing sexual abuse on their website. Body image. So interestingly, there's been recent research to suggest that there's quite a bit of overlap between autism and eating disorders, specifically anorexia. So if you think about it, it makes sense to some extent. There's that rigidity surrounding eating, routines. So there has been some evidence to support that women with eating disorders also have been diagnosed with autism. And as women enter adolescence, or as girls enter adolescence, body image may become a source of worry and anxiety for many young girls. So we need to make sure that we stress that all bodies are different. We need to stress these concerns early on, and discuss examples of appropriate versus inappropriate body images, especially with all of those odd examples of body shapes that are out there in the media, right? Supermodels, women with 10-foot long legs, and all of these other examples that just aren't realistic appearances for us to strive towards. So you could do this in the context of the media. You could use visuals such as the top one there described to differentiate what is an inappropriate versus appropriate body shape, what's healthy versus what's unhealthy. And so we also need to think about support within the family context, right? So there has been a lot of research out there to support that parents of individuals with autism experience higher stress related to parenting than parents of individuals with intellectual disability or another form of developmental disability. And there's more and more recent evidence to suggest that mothers of women with autism experience higher rates of chronic strain than men. And I think a big source for this is because of just the disparity that women with autism face, right? So there's difficulty getting diagnosis, difficulty getting healthcare needs met. There's a lot of areas that we need to be working on as a community to adequately support females. So I really like this idea from Yuri Bronfenbrenner, the family systems model, the idea that in order to effectively support females with autism, we need to do so within the context of the family and the peer system, peer groups. So if you are a caregiver, if you're a relative, if you're a family member or a parent, making sure that you connect with other parents of women or girls with autism so you can form opportunities for women with autism to connect as well as yourselves and relate and share those experiences. We now have about 50 people in the room who are interested in autism and women, so maybe this is a good forum for us to talk about if we should form a Charlottesville chapter of women with autism or something like that. And then finally, we need to focus on using a strength-based approach for women and girls. So thinking back to Agony Ortiz's video, she expressed a lot of frustration and anxiety surrounding getting a diagnosis. It took a long time for her, and it takes a long time for many women. And this has been reported in interview-based studies that it promotes a lot of difficulties surrounding identity formation for young women with autism. Who am I? What does this mean about me? So one example of helping support the strengths of an individual is focusing on how she would like to describe herself. I think a lot of us in the room prefer person-first language, a person or a woman with autism, but women and men with autism more recently have been saying that they prefer to be identified as an autistic person because they view autism as an identity rather than a diagnosis or a label. And this is, I think, important from the perspective of focusing on autism as a strength rather than a diagnosis. We need to define strengths of women and girls that we have in our lives. So involve her in identifying what those strengths are, so she can tell you things that she likes, things that she knows a whole lot about, things that she's good at, and using those strengths and those areas that she enjoys as ways to best support her and motivate her as she develops into a woman. And then involve her in identifying her own quality of life. One interesting quote that I read from a study conducting focus groups with women with autism was that even though people around these women reported their quality of life as poorer, they themselves didn't perceive their lives that way. And they themselves actually thought that facing challenges and adverse life events was beneficial to them because it helped them build resilience. They coped with those events, they got through them, and it gave them a greater sense of self-esteem. So I think for those of us who are professionals or family members supporting women and girls, we tend to focus on the injustices. I can't get my girl the supports or the therapies or the interventions that she needs, but also focus on the perspective of she's been able to get through all of these life events so far successfully to some extent. So, and these experiences are going to provide resilience and opportunities to grow. So, before we open up for questions and comments and your own reflections on experiences, Erica and I put our heads together and thought, what are some areas of future research we need to focus on when we're talking about girls and women with autism? So first and foremost, I think, of course, we need to address the diagnostic challenges surrounding how we identify women. There are some tools that have been put out there, as I mentioned, but we need to further refine tools for verbally fluent girls and women and test those out in larger groups. We also need to figure out what is it about autism that is gender specific versus gender independent. So what can we say are characteristics of autism that we're going to see across the board versus what are characteristics that are going to be very much different between males and females and how they're presented, because I think that can help us better figure out how to support an individual. How is the likelihood of developing autism linked to gender? So right now we estimate that there's a 4-to-1 male-female ratio or 2-to-1, depending on various variables. So we need to further look into this question to see how much is it linked to gender, and then what developmental mechanisms are implicated by gender. So when we're looking or working or supporting, or when we ourselves are someone with autism growing and developing, how much of those developmental experiences are predicted by having autism versus being male or female, because I think that can help us better tailor how we support and individualize the supports that we provide our loved ones. So a lot of the research that Eric and I found for this presentation was limited by small sample sizes, by unequal gender groups or sex groups. So of course, for future, we need to do better about gathering equally sized groups of men and women and girls and boys to conduct this research, so we can actually more effectively determine what those gender differences are. And we also, on top of that, need to do more work to further develop interventions for a variety of different areas: social skills, life skills, healthcare access. This is particularly the case for women with autism who also have co-occurring severe to profound intellectual disability. There's very little literature out there right now to share that tells us how to support the mental health needs of women with autism and severe to profound ID. And then we also need to involve more sophisticated measurement techniques beyond just parent report or behavioral observation, whether this be through the use of eye tracking, neuroimaging, etc., to help us further differentiate how men versus women behave so we can diagnose them better, and how men versus women behave so we can better support them through interventions. Okay, over to Erica.
Yeah. So in the dual spirit of increasing supports for females with ASD, and in the spirit of continuing to collect some data to inform what supports might be effective, we are planning our EVA to run a group social skills program probably in late spring of this year for females with ASD. And so we're sort of in the preliminary phase of figuring out exactly, we'll likely use an established curriculum for social skills and or emotional regulation, since we know that can be a challenge in ASD and females in particular, and look at what kind of interests we have in determining what the specific age group might be, whether it be children or adolescents or young adults. But just wanted to put that out there to this group. If you yourself are interested, or you know of someone who might be interested, please feel free. You can email me, and I'm going to have a sign-up sheet at the back, but just wanted to get a sense of what kind of interest we have in the community so that we can start to build ideas for the group and hopefully provide that. Questions? Yes.
So I have a question about, near the beginning you were saying that we were talking about camouflaging, and that a lot of times in schools girls don't stand out as much as boys. So is there research about who on the whole is referring girls? Is it parents? And who is making the diagnosis? Because I know you can get a diagnosis through school special ed teams or even their medical diagnosis. So who is noticing this, and who is actually giving out the label?
Yeah, that's a good question. Oftentimes, and this is from my clinical perspective, but oftentimes it seems to be coming from parents who have noticed that their daughter is coming home and reporting a lot of difficulties, or just the increasing social difficulties may start to be noticed as the child gets older. I haven't run across any specific research looking at who in particular is diagnosing girls as opposed to boys, or who's referring, sorry, because like you said, we know it's a wide range, but oftentimes what we've seen is that those girls have not yet been identified in schools, like with an educational placement under the autism category, and that they're coming to us looking for that. And then similarly, later on, we are actually getting quite a lot of referrals from adults who are self-referring, wondering about whether this fits for them in the community here. So I think that's something that we're really trying to address and figure out how to better support too.
Are these questions related to more broadly the presentation on her social skills group? Social skills? Okay.
Correct. They all grow up. So my wife and I have 32 years worth of experience. Mm-hmm. It's not professional, it's of parents.
Yeah.
She's in our house. She's a wonderful young woman. So isolation is a huge, huge issue. And the ideas that you talk about in the presentation in terms of peer interaction, peer mentoring, et cetera, it's extremely difficult to get started. I can see that one can live very well in the school environment, and I can see that the funding is there to make it happen. Mm-hmm. But the chasm is there whether male or female, and our daughters create the unique challenge for all the things that you mentioned. Mm-hmm. So I encourage you to expand that, but I appreciate you can't put a 32-year-old who presents as an 18-year-old, by the way, mm-hmm. in a room with 16-year-olds. Okay, that's one. The other thing that I didn't see in there, and maybe it's implied, is the impact of social media. Mm-hmm. Entrapment.
That's a good point.
Device. If anybody wants to hear how bad it can get, they can talk to my wife or I. And also as a tool for basically obsession in lieu of other social interaction. So those are two comments, and the other is I applaud this.
Okay, now I'm going to pause and resume the questions.
Did you